So our next speaker is Dr. Klane White. He's the chair of pediatric orthopedics at Children's Hospital Colorado and professor of orthopedics and pediatrics at the University of Colorado School of Medicine. He's the Rose Brown Endowed Chair of Pediatric Orthopedic Surgery. He specializes in pediatric musculoskeletal disorders, skeletal dysplasias, and rare genetic disorders like the mucopolysaccharidosis. Could we get Dr. White on the platform, please?
Morning. Or,
Afternoon.
or afternoon, I was going to say, as it may be, depending on where you are. It's West Coast, East Coast, we're right at that precipice. So,
So go ahead and share, and the program's
uh,
all yours, Wayne.
great. Thank you. Thanks, Joe. I want to thank Joe and the Munzer MPS Center for inviting me to be part of this talk. I've been part of some of these master classes for the several years now, and it's always such a great audience. And hopefully, I'll be able to add to your growing knowledge base if this is a field that's somewhat new to you. So a few disclosures. None are relative to this talk. However, this is a lot of my research around achondroplasia. Um, so just to kind of start out with some basic stuff, dysostosis multiplex is the skeletal disease that's been associated with lysosomal storage disorders and specifically MPS and ML. It's a diffuse skeletal disease that's probably GAG mediated, but what it results in is progressive deformity in young children in early life and joint degeneration in later life, so arthritis. Um, and so we're kind of going to talk about the different aspects of life and how bone disease affects individuals with MPS. So for those of you less familiar with sort of the biology of growth, the growth plate sits at the end of our long bones and it's several synchondroses within the base of the skull and the spine. And basically what happens is there's a cartilage layer that then grows in a very organized manner at the ends of these bones. And when you have lysosomal storage disorder, specifically MPS, this can affect that biology. It's not just a storage space, but it's an inflammatory biological issue, which then causes disruption of growth. And this results in that deformity. Now, there's also biological and inflammatory issues, which can result in joint and cartilage disease, which we'll get to in a bit. I think when we're talking about orthopedics, I think we always have to start with, will my intervention change this person's quality of life? Will it improve their function? Will it decrease their pain? And here's sort of a little checklist of quality of life issues such as sleep, happiness, mental health, daily living tasks, job security, social life, and I think oftentimes the most important issue is pain management. And if we are going to propose an intervention, we need to make sure that it's going to have a positive benefit in regard to those issues. There are alternatives to surgery. So again, before we propose surgery, we need to think about what are our options that are lower risk. Every surgery has a certain amount of risk and a benefit ratio that we need to consider. So, and if you don't do surgery, there's no surgical risk, but there can be some opportunity cost. But that can be mitigated by weight loss. It can be mitigated by use of assistive devices. Here you see a bunch of children with strollers and wheelchairs that are helpful. You can use orthotics, braces, shoes, or just pain relieving medications. Sometimes these are oral anti-inflammatories. They can be corticosteroid injections, or there have even been investigated the use of potent biologics, which seem to be helpful in certain individuals. So that leaves us to those who don't benefit from these non-operative options. So when do we operate? Well, if the pain and deformity limits everyday activities and is not amenable to these other options, pain at rest at night is always a significant issue. For the spine, we're always worried about neurologic deficits. And as you just heard in the previous talk, you can sustain peripheral neuropathies, which can affect function and generally need to be addressed. Sometimes, but we don't really have a great handle on this, is the natural history. We know that, say, a subluxated hip is going to do poorly. And so even if it's not painful and it's not limiting their activity, we'll sometimes consider intervention. And I'll talk about that more specifically as we go forth. I show this only not to, and I'm not even sure how accurate it is anymore, but this is from our 2009 paper, but this just goes to show that every MPS disorder has some level of bone disease that needs to be dealt with, whether you're talking about the neck, the thoracolumbar spine, you're talking about hips, lower extremities, or peripheral neuropathies. So cervical, I'm going to kind of do this anatomically, starting from the head and working our way more or less down to the toes, maybe with a little diversion to the hands. But so the cervical spine in MPS is one of the most feared complications in these disorders. It is has a high risk for significant morbidity and even mortality. And unfortunately, this is generally a condition that can't be treated without surgery. So it's more or less a waiting game until it's time to operate. So why do children with MPS have problems with cervical narrowing or instability? Well, you have delayed ossification of the odontoid process, which results in instability of the C1, C2 level. You can have narrowing or underdevelopment of the posterior ring of C1. You can have ligamentous or dural thickening. So the lining of the spinal canal can be thick, which causes narrowing of the spinal canal. And as I showed in this video, you can have instability of C1 and C2 as a combination or as a part of these other issues. And in the end, what this results in is spinal cord compression. So how do we monitor for spinal cord compression? Well, imaging is really our best modality in addition to physical exam. I'll talk about both of those. So imaging, we tend to follow or at least screen for instability using lateral flexion extension radiographs. Shown here, you can see the difference in what we call the space available for the cord. This is the space between the back aspect of C2 and the anterior aspect of the posterior ring of C1. This can be better evaluated with CT and MRI. There are special tests that we can get, such as a flexion extension MRI if we're not sure. This gives us a lot of detail about the health of the cord and the dynamic contribution to that health. And then finally, CT or MRI angiography, which is really reserved for pre-surgical planning. Here's another X-ray showing the change in relationship between C1 and C2. On the left, you see the anterior arch of C1 sits just flush with the posterior body of C2. That in itself is a little abnormal, but then when you look at the relationship of those lines, the anterior the arch of C1 moves forward significantly relatively to C2, and then you can see where that star is. That's the space over the cord, and that changes significantly. So this is going to result in some kind of some level of spinal cord compression. This is a CT of a similar situation where you can see that ring of C1 sitting over and anteriorly to the ring of C2, and right behind there, and I don't know if you can see my pointer, but there's less available space for the cord. The same child, you look at the MRI, you see that blush in the spinal cord. That is a bruise in the spinal cord because of that instability and that narrowing, which is clear on that MRI. From a physical exam standpoint, we're really looking for myelopathy or upper motor neuron signs. So myelopathy is clumsiness, weakness, unsteady gait, or changes in bowel or bladder function. Upper motor neuron signs would be hyperreflexia, signs of a Babinski or sustained clonus. In cases of neck instability, they will sometimes try to hold their neck still, and that can result in muscular neck pain or even headaches. So when we have symptomatic spinal stenosis, whether that's due to instability or just straight narrowing, we will need to do surgery. So what are the indications for surgery? Well, if we start seeing neurologic changes, whether that be on exam or signs, as I mentioned, of myelopathy, then it's time to intervene. If there's really obvious instability without neurologic changes, then sometimes we will intervene because this is just an accident waiting to happen. And as I showed in that MRI earlier, if you have evidence of cord injury, that means the cord's already being stressed and it can only get worse. And so these are the times that we will intervene with surgery. And so what does surgery look like? Well, this is more or less what we're doing. We're going to be removing that posterior arch of C1, and then that allows space for the cord. And then what we're going to do is put some instrumentation in and stabilize that. You can, there's many ways to do this. This is one way. You can stabilize it to the neck. You can just do the C1, C2. But what this does is stabilizes that atlantoaxial joint, and but still allows significant motion of the neck, and protects that spinal cord. And this is, oh, I apologize. But you can see the lateral instability here, this C1 moving forward on C2, and then this was fixed with C1, C2 screws. So a slightly different variation than what I showed in the video. This is an MPS 4 patient where, again, you see instability on flexion extension films. And here's the MRI, which shows narrowing of that space of the cord. There does not appear to be spinal cord injury at this point, but again, as I mentioned earlier, if you have obvious instability, particularly with Morquio syndrome, that really has an unfavorable natural history. And so this patient ended up with a similar surgery to what I showed in the video, with stabilization of that joint. Moving down the spine just a little bit, this is a very much underappreciated aspect of MPS, is cervical thoracic disease. So at the base of the neck, you can get a gentle kyphosis, or some kind of or sometimes even some disc protrusion or prominence, and there might even be plenty of room around the spinal cord. But because of the way that the spinal cord drapes over the spine in the front, this puts the kids at risk for myelopathic changes in the spinal cord. This is, and I think I talk about this a little bit more later when we talk about anesthetic risks. So this is a patient with MPS 1 who had an MRI right before hip surgery, because I was trying to combine anesthetics because of concerns about airway. Well, what I didn't appreciate was how this cord was draped over the spine. This was in 2009. I did this what I considered a beautiful hip surgery. And then if you look on the right, you can see that change in spinal cord intensity. This patient had a spinal cord infarct and was paralyzed. And I can tell you from personal knowledge, there are at least 24 children in the United States alone who have had lower extremity surgery with similar situations, who have had well-intended surgeons who ended up doing very nice surgeries of the hips or lower extremities, and the patients will never walk again. Something to be very aware of. So moving down the spine, the thoracolumbar kyphosis, this is sort of the quintessential deformity for MPS. This is the most common spinal deformity in MPS, and certainly for MPS 1 and MPS 4. This is a condition that we don't typically try and brace or treat. We more or less observe. The vast majority of them don't progress and don't present a problem. But when they do, they can result in neurologic compromise. And here you can see this child reaching over in that very classic gibbous deformity. So how do we treat this? Well, we need to do posterior osteotomies, meaning taking some bone out of the back. We do instrumentation and fusion. We may even do some work from the front if necessary. In this case, you can see where the arrows are. You see that where the bones are now fused in the front with posterior instrumentation, and like assuming a fusion in the back. And so what we want to do here is get a nice balanced spine to achieve stability and healing. We back this up with a brace because the bones are relatively small for about 3 months, and that's how you can achieve a successful outcome. Many people will try and treat these with just posterior only procedures, and a very large percentage of those end up failing. So if you're working with a surgeon, just make sure that they do address the anterior aspect of the spine. And this is just what that surgery looks like. Again, this is all from the back, but you can see we're taking bone out of the front of the spine by coming around. We put the instrumentation in, we put the bone graft in, and fuse them. And so then, by doing this, we have achieved a nice balanced spine outcome. And this is just an example of one of my patients. It's a little hard to make out that gibbous deformity. You can make it out better on the MRI, but I will tell you it's worse on the standing X-ray than the MRI because the MRI is supine. And then here you can make out that this is now a very straight spine. It's a little harder to appreciate the bone graft that's in the front of the spine that I put there to help give it that anterior support. Scoliosis is a little bit of a different beast from kyphosis. When we think about kyphosis, we're mostly worried about neurologic compromise. When we're talking about scoliosis, we're talking about pulmonary compromise. And this is a more extreme version of a patient with Morquio syndrome, but you can see how the rib cage is extremely distorted and rotated. And so what this results in is restrictive lung disease in patients that probably already have an element of this just because of their glycosaminoglycan accumulation. Treatment is actually relatively standard compared to other children. It's casting and bracing. Growing rods are sometimes an option, but we will consider definitive fusion up to as young as age 8 or 9. Whereas for more idiopathic type scoliosis, we try to wait longer and we'll be a little more aggressive with growing rods. And just know that as with any other surgery, MPS patients are at a higher risk for complications, whether those be respiratory or implant related or other problems. I will say though, these patients do heal just fine. Their bones just tend to be a little bit smaller and maybe a little bit softer. So this is an MPS 4 patient who had a scoliosis, and maybe you can appreciate on that lateral view on the right a little bit of a kyphosis as well. So in this surgery, I attempted to kill 2 birds with 1 stone. You can see this long fusion to treat the scoliosis, but you can also see how we flattened out that kyphotic deformity at the thoracolumbar junction by doing posterior osteotomies and getting this addressed. Moving down to hip deformities. So there's 2 issues that occur here. One is epiphyseal dysplasia, which sometimes is called osteonecrosis, and many patients will be referred for Perthes disease. So to be clear, Perthes disease is idiopathic osteonecrosis of the proximal femoral epiphyses. So if the patient has MPS, by definition, it is not idiopathic and it is not Perthes disease. And the treatment of Perthes disease is very different than it is in MPS. So again, if you're advocating for your patient and you're sending them to your local pediatric orthopedic surgeon, they need to understand this because they will go down the wrong road if they misunderstand this. The second part of this is you can see where the arrows are. These hips are subluxating as well. We don't usually see hip subluxation in Perthes disease. And so particularly with Morquio syndrome and with Hurler syndrome, you see this subluxation of the hips. Other forms of MPS are actually tighter, so for Hunter syndrome and for Merritt-Lemay, we actually don't really see hip subluxation. And so it's a little bit of a different dynamic and we treat them differently. Regardless, all forms of MPS do have this biological epiphyseal dysplasia, which results in hip arthritis. It can be as young as adolescence, but usually as a young adult and will need to be treated accordingly. So here's a normal hip x-ray on your left, and on the right, this is a young Hurler patient. I think you can appreciate the difference in the coverage of the femoral heads. These hips are subluxated, and the epiphyses are small. At this point, we don't see a whole lot of epiphyseal dysplasia. So what do we look for in x-ray? Well, we're looking for what we call a break in Shenton's line. This is where the femoral neck should line up with the superior pubic ramus. We see a high neck shaft angle, which results in coxavalga. We see a very small acetabulum with a high acetabular slope, and this combination of defects causes that hip subluxation and even true dislocation. How do we treat this? Well, we can do a pelvic osteotomy and oftentimes combine this with a femoral osteotomy. Certain centers will perform a shelf acetabuloplasty, which is more or less a variation on the hip procedure. It's more of a technical difference if you're not an orthopedic surgeon. But basically what you're trying to do is get these hips centered and covered so that they don't subluxate. But I think what you can appreciate on this x-ray on the right is those hips are centered, but those proximal femurs are not round. Okay, so this patient for now will do well because their hips are not subluxating, but that epiphyseal dysplasia, that osteonecrosis, is going to be a biological problem that will not go away and will cause them problems somewhere down the line. And this is just another version of what we do. Again, the femoral osteotomy, and then what I do is called the San Diego type osteotomy, where we are bending down the acetabulum and putting bone graft in there to get this hip centered and covered. But even this patient at a young age, this is a Morchio patient, I think about age 5 or 6, and you can see that the epiphyses are not round. They're very underdeveloped. So this is just another video showing kind of what we do for a little more clarity. This is the femoral osteotomy. We call it varus osteotomy. We're pushing that femoral head into the acetabulum, and then we cut the pelvis above, put a piece of bone graft in there, and that's how we keep the hip well covered. And if you look at the difference between the left hip on the right and the right hip, which is on your left, and the left hip, which is on your right, you can see how that changes that anatomy and that relationship between the femur and the pelvis. We do have some data on outcomes for these. I will say that over the long run, these patients don't necessarily do better with surgery, and I think that's largely due to the arthritis and the biological aspect. I will say in the short term, patients who have hip subluxation tend to do well and I think by doing the surgery, we can buy them a good 10, sometimes even 15 years of an asymptomatic hip. Whereas they would otherwise have a symptomatic hip at a younger age. It also gives us some technical benefits with regard to hip replacement should they need that in the future. But here's a Minnesota study looking at patients with Hurler syndrome. You can see out of the 102 hips, 5 developed severe osteoarthritis, of which 3 were from the surgical group and 2 from the non-surgical group. This is the Irish experience, and if you kind of look at where this yellow box is, degenerative changes to the hips, you see a lot of advanced arthritis in these hips. And this is a radiographic outcome. It's not a functional outcome, but nonetheless, the point is that by doing hip surgery, we do not stop the biological process of epiphyseal dysplasia. So what happens to those hips that have that continued biological problem and they develop high arthritis? Well, they are candidates for hip arthroplasty or hip replacement. And this works well in MPS patients because they tend to be low demand. So because of that, we're not as worried about these hip replacements wearing out quickly. And so this can be done at younger ages. Clearly, patients with MPS have more medical comorbidities, and because of their anatomy, they're technically complex. This is not the same as, say, hip replacement. I always used to use the analogy, this is not your grandmother's hip replacement, but now I'm old enough, it's not my friend's hip replacement surgery anymore. So my siblings are all getting hip replacements. So I have to change that. And just for those of you not familiar with what a hip replacement looks like, here you can see the arthritic hip, and then they go ahead and ream that out. They'll put this cup in there, and then they'll take off the top of the proximal femur. They will put an implant there. And I'm sorry, this one's a little slower because it's not mine. I couldn't speed it up. But if you just bear with me for a second here, there's a plastic liner that goes in there. So most of these hip replacements are going to be what we call a metal on poly construct. That seems to be the most reliable. There's bony ingrowth to that femoral stem. We almost never cement these anymore because that tends to cause more problems than good. And so now this is a prosthetic hip which relieves a lot of that arthritic pain. Moving down to the knees, the most common problem is genu valgum or knock knees. This tends to present fairly early, as young as 3 or 4 years of age. Now, knock knees generally are considered to be relatively benign compared to bow legs. But as you can see in this boy, his walking like this with his knees, literally knocking on each other, it does affect gait and mobility. So, and there's good literature support that correcting this valgus deformity of the knees results in improved gait mechanics. And so the way we do this is through a technique called guided growth. And so here you can see a patient who you can see the knock knee. So that yellow line is what we call the mechanical axis, and that should fall through the center of the knees. And on this patient, we put those plates in. Some people call them 8 plates, but that's technically trade name, and so that's like saying Kleenex as opposed to tissue paper. So I use the term tension band plates. You put them in on the inside of the knee, and this patient's actually slightly overcorrected now, and that's on purpose because in patients with MPS, they tend to have a fair amount of rebound deformity. So you want to slightly overcorrect them, take those plates out, let them rebound, and hopefully they rebound back to neutral. And this is what that surgery looks like on video. You expose the growth plate on the side that you want to tether. You lock that growth plate up on one side, and as they grow, the outside grows faster than the inside, and their legs grow straight. And again, once they slightly overcorrect, we go ahead and take those plates out. I will say the rate for reoperation is relatively high because of that rebound phenomenon. Moving on to carpal tunnel syndrome. I think you just heard about this, so I won't belabor it too much. Um, this is due to thickened tenosynovium around the tendons. So all the tendons that go through the wrist have a synovial lining, and that tends to be a site for glycosaminoglycan glycan accumulation. Not to mention, you also get thickening of the transverse carpal ligament. This is often asymptomatic. I would say the vast majority of the time it's asymptomatic, but you will see changes in function. And if you look at this photograph on the right, you can see all the gags, this white grouping of storage materials. And right here is the median nerve. Hopefully you can see my pointer. But that hourglass formation of the median nerve. And if we ultrasound this, actually the nerve before you get to the carpal canal is enlarged. And so it's a little counterintuitive when we look at these on ultrasound. And this is what it looks like surgically. We do that decompression. That lower picture on the right is again a nerve decompression. And you can kind of make out that median nerve that's been compressed there. I will say that, particularly in Hurler syndrome, they tend to get nodules in their tendons in their hand, and they get trigger digits. And so oftentimes we'll combine the carpal tunnel release with a trigger digit release. And if you look at these histologically, it's really interesting because it looks like every other MPS cell that's full of glycosaminoglycans, that we call the foam cells in those tendons. Tarsal tunnel syndrome, I get asked about a lot. It's not clear to me how much of a phenomenon this is. But theoretically, with tarsal tunnel syndrome, you do get plantar foot pain or tingling, and oftentimes it's confused with spine pathology. So there was a nice review of this. It's a small number of patients, but they had 4 patients with suspected tarsal tunnel syndrome. 3 of them underwent decompression, 2 with good result. And one of those 4 actually ended up having spinal stenosis, which improved after the spinal decompression was performed. So it ended up not being tarsal tunnel syndrome at all. So just if you're thinking about tarsal tunnel syndrome, I think the take-home message is, yes, you can check for it. You can do nerve conduction studies, but they're not always reliable. But make sure it's not a spine problem. I promised to talk a little bit about anesthesia. And I'm not an airway specialist, and I'm certainly not an anesthesiologist, but I feel it's my responsibility to make sure that these patients are safely cared for when I take them to the operating room. So that requires a very thorough preoperative pulmonary, cardiac, and ENT evaluation. And so I do lean on my genetics colleagues, my metabolic genetics colleagues, who really tend to be the primary care home for these patients to help coordinate this. And I certainly lean on them to guide me in terms of how much we need to worry about their anesthetic. A skilled airway personnel is critical. And, sadly, we had a death in our hospital this year for a patient with Hunter syndrome. And they were in a procedure center with what I would assume, we have very good anesthesiologists, but I don't, and I don't know the details of what happened, but, you get into these situations where they paralyze the patient, but then they can't gain access. So it's a you can't ventilate, can't intubate situation, and the patients, this is a well-known phenomenon where patients expire. so, again, it's our job to make sure that that everyone in the room is prepared. And even in this case, they were there for an ENT procedure, and the ENT couldn't even get a tracheostomy, given the anatomy. So just, we always, but I do not take lightly the consideration of recommending surgery for my MPS patients. And so I think if you're in that position where you're overseeing the care of these patients, it's really important that all your T's are crossed and all your I's are dotted. I mentioned neuromonitoring earlier. All cases that exceed 45 to 60 minutes, depending on who you ask, really need to have neuromonitoring through that case. Because there's a very significant misunderstanding that the issue here is their neck, and it's not. It's that cervical thoracic junction that I showed earlier. We don't totally understand this. It's probably some combination of small vessel disease associated with hypoperfusion from relative low blood pressures in the operating room, an inability for the body to self-regulate and protect itself. And so if you're overseeing a patient with MPS who's going to surgery, please make sure that this has been considered. And this is what I showed you earlier, that same case, and this is what it looks like in the operating room. I will say epidural anesthesia has been implicated in these cases. I think it's more that epidural anesthesia masks the problem. If they can't feel or move their legs after surgery and they have an epidural, then oftentimes it's attributed to the epidural, when in fact it probably is not. To be fair, if you have an epidural, they're usually not a complete motor block. They're usually a sensory block. So if there's any motor loss after surgery, you need to really be worried about whether it's a spinal cord injury or not. There's a program that's now kind of being widely adopted amongst pediatric spinal deformity surgeons, which has been known as Spine at Risk. There's significant literature now on this, which recommends this neuromonitoring that I'm discussing about. And I'm happy to direct anyone in that direction if you need that information. So I'll sum it up with the key learning points here is that spinal cord compression is common in all forms of MPS or ML and really requires regular evaluation and surveillance, whether that's imaging or physical exam or a combination of the two. Hip dysplasia is most common in Hurler syndrome and Morquio, and should be treated when a subluxation is appreciated. The epiphyseal dysplasia, the biological component, we see more in Hunter syndrome, Meritor-Lemay. I will say, SLY syndrome or MPS 7 is pretty uncommon, but I have seen, probably a half dozen of these patients now, in which you see some, they tend to behave more like Hurler patients. So I guess I'd throw them into that category. But long story short is that all these patients, whether you treat them surgically to fix their subluxation or not, can result in inflammatory disease of the joints, which then can result in arthritis and is treated with joint arthroplasty, usually relatively later in life, but as early as adolescence and young adult life. Genu valgum develops early in childhood, is responsive to guided growth, which is a relatively low risk surgery. Slight overcorrection is recommended, and rebound is common, and they might need a second surgery. Peripheral neuropathy is common. You heard about this in the last talk. So, but just routine surveillance with nerve conduction studies is recommended. These patients will not tell you that they're having symptoms for the vast majority of the time. Surgery, please just be careful. The airway management, cardiovascular management, spinal cord protection. These are all issues that are real and put these patients at extremely high risk for any surgical intervention. And that's not just orthopedics. That could be any kind of other procedure that goes on for any amount of time, or even if it's in the procedure center, as I just discussed, where they'll just be having a laryngoscopy and ear tubes or something simple like that. You always have to be on high alert.